So, um, so identification method for the herpes simplex virus. The preferred mode for identifying them is PCR. One thing about this diagnostic test is that they don't really ask them. They rarely ask diagnostic test like which one is the preferred one. That should be more of a step two question. But what they can ask us is okay, what is the organism that is the test is suggesting. Maybe they did PCR, no, not PCR, let's say the TZAC test now, and they were able to display the finding, maybe this image A that we are seeing, and they're asking us what's the possible organism that we are looking at. So we must be able to know the relevance or the diagnostic significance of this test. Not that, so I don't really feel we need to know that okay, this is the preferred one, this is the one. No, just know that okay, when they do this test, if they see this, this is what it represents. So PCR is still the best modality for diagnosing the human herpes simplex virus, and because we know that most of them affect the CNS, like the type 1, which is the human herpes simplex type 1, the type 2, as well as the type 3. They can cause, they can all cause, okay, type 1 and 3 can cause encephalitis, type 2 can cause meningitis. So you might want to obtain CSF sample and do the PCR analysis in order to do the sequencing of the DNA, and you see if it's in keeping with any of them so that you can make your diagnosis. You know that if you do CSF culture of a virus, you won't grow anything. So you won't grow anything. Viruses are causes of aseptic meningitis. We are going to talk about that later. Another test you can do to make diagnosis of the HSV aside PCR includes what we call the TZAC test. And we have seen a question that tested this. So what we just do for the TZAC test is just to obtain a sample of the vesicle. So we obtain a smear, we observe it in the microscope after doing some staining that they do. So they tend to see multinuclear giant cells. So those viruses, causes some epithelial cell changes. So they have an increased nuclear size, they have increased cell size entirely, and they appear like giant cells. So those are the cytopathic changes that these herpes viruses do to the epithelial cells that they infect. So those are these cells we are seeing are not actually macrophages. They're actually epithelial cells that have undergone transformation due to their cytopathic um, response to herpes virus infection. So they become large and they look like white blood cells. So once you see multinuclear giant cells, following a TIGDAC test, and it's appearing like this, you see them in clusters, you know that this is likely to be one of those herpes simplex, maybe herpes simplex virus 1, 2, or the third one, which is the varicella zoster infection. So the three of them can have this kind of multinucleate giant cell appearance with the TZAC test. So it's very common for them to show us this TZAC test. We just obtain a smear of the vesicle in the genital, and you are going to see aggregate of multinuclear giant cells, which are large epithelial cells that have transformed from their normal size to abnormal size of resemblance of the lymphocytes because of the infection from the simplex virus too. So that's that about the TZAC test. Then the last one we can do is to obtain a biopsy. We observe them in the microscope and we see what we call the Crowdry-Hay inclusion. So this Crowdry-Hay inclusion is common to the three organisms that we've talked about too. Simplex 1, Simplex 2, and the varicella zoster. So you see the Crowdry-Hay inclusion, which are intranuclear eosinophilic inclusion. So they're actually formed by aggregation of the nuclear protein with the membrane. So those nuclear proteins from this organism, they fuse together with the membrane and they form those inclusions. So you can also find this crowded B inclusion in uh, CMV infection. So someone that has a cytomegalovirus infection, human herpes virus type 5, they can have Cowdry B inclusion. So don't worry, if they are going to test anything about this Cowdry, they are going to mention it. So once they mention it, you know what they are talking about. So Cowdry A is for the 3. It's for the 3. You see this Cowdry A inclusion in the 3, this type 1, 2, and the varicella zoster. while Category B is for CMV infection and some other infection that it's very rare for them to test. Yeah, so what are the receptors that are used from by some of these viruses? Yeah, even here we are going to be including some viruses that we have not even talked about. So it's just a summary of the receptor that is used by all the viruses, that gain entry into the host cells via receptor mode. Yeah, so what's the first one? CMV. So we have to just learn this. Cytomegalovirus uses heparan sulfate. So they use integrins on the epithelial cells that they want to infect, and that integrin is made up of glycosaminoglycan, particularly heparan sulfate. So heparan sulfate is for CMV. Integrin that they use is heparan sulfate. CMV, Epstein-Barr receptor it uses CD21. That's what it binds to. So they can test any of these. I think I've seen them test EBV. I've seen them test HIV, rabies, and parvo. So they can test. I think I've even seen rhino too. They can test any of them. You have to learn it. You have to learn it. So HIV. Hello.
Yeah, hello. I said yes. I just said yes. That was all.
Like you've come across some questions testing these receptors, Abby.
Yes, yes.
So it's something we need to note. So CMV uses integrin. Integrin is made up of heparan sulfate. HPV binds to CD121 receptors on B cells. That's how it enters and infect those B cells. HIV uses CD4, CXCR4, and CCR5. So this CCR5 is majorly in the macrophages. So CXCR4 is predominantly in the T cells, and CD4 is also in the T cells. So that is why HIV typically affects both the macrophages and the T cells. That's that about HIV. Parvovirus B19 influence. We said that yesterday that it affects precursor red blood cells. So those precursor red blood cells, it binds to the P antigen on those precursor red blood cells to gain entry into them. So you can remember now from the name Parvo P antigen on the red blood cells P. So the way I remember rabies typically um causes problems with the skeletal muscle, paralysis, and all those things. So, we know that the receptor that is in the skeletal muscle is the nicotinic acetylcholine receptor. So we've said this already. We said nicotinic acetylcholine receptor is present in the ganglion and as well as the neuromuscular junction. So rabies takes advantage of those nicotinic acetylcholine receptor that's present within the skeletal muscle to cause the paralysis that it brings about. So that's rabies for you. Nicotinic acetylcholine receptors on the skeletal muscle, like within the neuromuscular junction. That's what rabies does. You guys remember that rabies also uses those external transport. You remember when we were doing biochemistry, we were talking about some organisms that use external transport. We talked about rabies, we talked about herpes, we talked about do we remember any other one? I remember them, but I just want us to also say it.
Tetanus.
Yeah, tetanus. So tetanus, they use both these um dining ham and what's the other ham that they use? The other transport protein, apart from the dining.
Kindness. Is it kinesin?
Yeah, so kinesin. So you use kinesin for the reactivation. They use the dining for the initial latency. Yeah, so rabies also uses those guys to hide within the neurons and come out again to cause the infection. Rhinovirus, this one causes common cold. Common cold is one of those RNA virus. It binds to the ICAM receptor, ICAM1 receptor within the epithelial cells. So ICAM receptor is one of those addition molecules that we are going to talk about in pathology. So it binds to the intracellular cell addition molecule, intracellular cell addition molecule, uh, ICAM1. That's what rhinovirus binds to, ICAM, ICAM. Yeah, you know. So that's that. Then SARS uses acetylcholine too. So you must always remember this acetylcholine association. Acetylcholine enzyme 2, acetylcholine converting enzyme receptor 2. So acetylcholine converting enzyme, I said acetylcholine, angiotensin 2 converting enzyme receptor 2. Angiotensin 2 converting enzyme receptor 2. That's what our SARS-CoV use. So if you guys remember um ACE, what other organism come to your mind? elevation of ACE, angiotensin converting enzyme uh increase. What other disease we talked about? You guys, can you guys remember? There's another disease that we talked about that share with increased activity of the ACE enzyme. Which one is that, Dr. Abisala? Simply about saying.
This is sarcoidosis.
Yeah,
Did you say
yeah, that is sarcoidosis. I said a disease. I think I made a mistake before. Maybe I was saying an infection. Okay.
yes.
So sarcoidosis. Always remember that sarcoidosis there's increased activity of the ACE enzyme, the angiotensin 2 converting enzyme. So that receptor, that ACE, 2 receptor is used by the COVID. Don't forget. Rhino, ICAM, rabies, paralysis, nicotinic acetylcholine receptor, parvo, P antigen, HIV, CD4, CXCR4, CCR5, Epstein-Barr infects B cells, CD21, CMV, integrin. Yeah. So so let's talk about those family of those RNA viruses one by one. So all of them, they they replicate in the cytoplasm, except retro and influenza that replicate in the nucleus. All of them replicate in the cytoplasm except retro, which is um, the family for HIV, as well as the human T leukocyte T um, T virus, T cell virus. What do you call it now? Human T cell virus. What's the proper name? I don't know how to call that. Human T lympho. I think it's lymphocytic virus or something. I've forgotten what the health. I think it's lymphocytic. So it causes adult T cell leukemia, HTLV. So both HTLV and HIV belong to the family of the retrovirus. Then influenza virus, don't replicate in the cytoplasm. It does its own in the nucleus too. Yeah, so let's take them one by one. We're already familiar with the. So I said that almost all of them are enveloped. All of them are enveloped except the first four that we talked about, and we use the acronym PETCH to remember them. So we said we remove the E to remember the envelope. So I think it makes sense when we say that okay, the acronym to remember the viruses that are not enveloped is PETCH. So because we are saying the one that don't have envelope, so the one that we have removed the E, which is the envelope, so we are left with PRCH. So P is for the Picona, R is for the Rio, C is for the Calicili, and H is for the
Charlie?
EP. Yeah, and H is for the EP. So we have removed the E, which is the envelope. They don't have the envelope. So Rio, is one of them, and Rio is the largest, and it's the only one that is double stranded. The other ones are single stranded. And when we were talking about the sense of the single stranded stuff, we said almost all of them are positive sense, except like 4 or 5 that are negative sense. And the way we try to remember the negative sense was just to say, remember the AB, which is arena, the booyah, remember the myxo, automyxo, paramyxo, and we had the FB, philo, and the rhabdo.
Hello. And the
So
raptor.
So just remember your AB, Arena and Bunya, your Mixos, Auto Mixo, Palamixo, then FB, which is the Philo, and the FR rather, Philo
FR
and the Rhabdo.
and the raptor.
That's all about the negative sense. Then we said you want to remember the segmented ones. I think there are about 4. You still follow your AB pattern. Arena and Bunya, they're always going together. Then the auto, then Rio.
And the real.
You see, that's it. So that's the Rio, is the largest, but in addition to being the largest, it's also segmented. So then auto, like we are always used to, we have always known auto to be segmented from our example of when we're talking about reassortment. It's the example that we used. Then arena and ibuya. So we don't need to cram off this table. You can summarize everything like that. So you know, and I feel that we don't really need to pay attention to the icosahedra helica. Nobody will ask us. Nobody will ask us. So it's just stress. It's just stress. Yeah, so let's take those organisms one by one. Real virus. Um, so real virus, the most important organism there is the rotavirus, and rotavirus is known to cause outbreaks of diarrhea, particularly in infants, in very young people. So once you see, it's the commonest cause of diarrhea in young people in the world. That one is basic stuff. Like you don't argue it. Rotavirus is the commonest cause of diarrhea in infants in the world. So, but the outbreaks is reducing now because of the live attenuated vaccine for rota. So there's a live attenuated vaccine for Rota that you can give children, but you just have to be very careful with the vaccine. Why? Because you don't want to give someone that has SCID or an infant that have had a previous history of um intussusception. Why don't you want to give someone that has had previous history of intussusception? Anybody? Can we just think about it from our knowledge of GI? So somebody comes in and tells us that okay, my baby had had intussusception at 2 years. Now it's coming at 3 years for Lota vaccine. So you don't want to give. Why?
Because probably to inflame the payer's patches and it will be a lead point for another interception.
Thank you, Dr. Zulia. That is the perfect answer to that. So it's going to be a lead point due to hyperplasia of the Pierce patches. That is it. So that's that you don't give it in people that have SCID. So severe combined there's reduction in the level of B cells and T cells already. So you might, and live attenuated doesn't mean that it cannot replicate in that host. You have just reduced the pathogenicity. If you further reduce the immunity of that kind of person, it can become reactivated and cause infection. So you don't give live attenuated vaccine in people that are immunosuppressed. So that's that about rotavirus. Diarrhea in young people. You want to pay attention to that. Diarrhea in young people, and it occurs in outbreaks. You know, commonly developing and developed country. It doesn't isolate. It's general worldwide. Yeah, and it's watery. It's not bloody. We already know the cause of bloody diarrhea. So once you are saying bloody diarrhea, you are thinking of maybe Shigella, you are thinking of Salmonella, you are thinking of Yersinia, you are thinking of Campylobacter. So if there's watery diarrhea, if there's bloody diarrhea in a young child, which organism want to come to your mind first? In a young child, bloody diarrhea in a young child. Based on all those highlights that we have been talking about, which of those organisms causes bloody diarrhea in a young child? Anybody? Do we remember?
Now could be enterotoxigenic E. coli. Sorry, enteroinvasive.
Campylobacter.
Yeah.
Okay.
So it won't be enterotoxigenic. Enterotoxigenic is for traveler's diarrhea. That's the peculiarity.
Yeah,
Traveler's
let's
diarrhea.
see.
Yeah. So it's not
Campylobacter, yeah.
it's Campylobacter jejuni. Okay. Um Picona contains the perch. So Picona is the family that contains the perch. So the perch polio, please. Polio, don't say Picona virus. There's nothing like Picona virus is just a family name. There's no a virus. We don't have a virus that we call Picona virus. But we have some viruses that are under that family name of Picona virus. So what are they? Polio is number one, Echo is number two, Rhino is three, Kozaki is four, Oman, I said Oman, hepatitis A virus is the fifth one. So what is the molecule that rhinovirus used to gain entry?
Right, which one are you saying?
Rhinovirus. What does it use
Hmm?
to gain entry?
ICOM.
I
ICAM.
can.
ICAM. What does Pavo use?
P antigen of the red blood cell.
P antigen of red blood cell. What of rabies use?
Rabies, nicotinic
Nicotinic
receptor,
acetylcholinesterase.
acetylcholine receptor,
Nicotinic. What does
Acetylcholine receptor.
what does CMV use?
CMV,
Integrin.
integrin, yeah,
Integrin. What does
parental,
we already know we know HIV. What about hepatitis? What about Epstein-Barr?
CD21.
CD21,
So you can see that it's very simple. That's all. So polio. Polio is the first one. Polio. We have two forms of vaccination for polio: the Salk and the Sabin. Sabin is the oral one. The oral one is more powerful than the Salk. Salk is the intramuscular one. So um, the intramuscular one contains the killed vaccine, while the Sabin, which is the oral, contains the live attenuated. So what you are going to get for the oral will be stronger. So IPV, that's in intramuscular, and the OPV oral polio vaccine. So they are not really, I'm not sure we are going to take polio as a disease entity. I'm not really sure, but let's see. But we already know about polio. Polio is more of paralysis. So it just causes paralysis, and you know you get it through the um fecal route. So it causes paralysis of the muscles. That's the basic presentation for polio virus. And echo virus causes aseptic meningitis. So that's one thing about echo. The major disease that it causes aseptic meningitis. So it causes inflammation of the brain meninges and brings about the symptoms of meningitis. So if you do your viral culture, you will not grow anything. So that's the word aseptic meningitis. You culture it, you don't grow any bacteria. So when there's a non-bacterial cause of meningitis, you call it aseptic meningitis. So it can be viral, can be fungal, it can even be from malignancy. Malignancy can cause meningitis. So like all these leukemias, you know, that go to the brain, cross the brain barrier, invade the brain, and all those things. They can cause aseptic meningitis. Rhinovirus is next. The only peculiarity about rhinovirus, we just have like more than 100 strain. So like the peculiarity for rhinovirus is just common cold. Just have the fever, you have the coryza, runny nose, sore throat and all those things. Kozaki is of two types. We have the Kozaki A, Kozaki B. So we said Kozaki A is one of those guys that can cause um, rash that involves the palm and the soles, just like our Rocky Mountain spotted fever and secondary syphilis. So Kozaki virus type A is the third. So what does it typically cause? It causes aseptic meningitis, just like echo. It causes and another thing that can cause aseptic meningitis too is polio. So I should not forget that. So let me go back again. You see, polio, echo, and Kozaki, they are known as enterovirus. Why? Because they are predominantly transmitted through the fecal route, and they are viruses. That's their major route where how they are transmitted fecally. They affect the intestine. They proliferate in the intestine. Before they now cause their respective disease that they want to cause. Polio will move out and go to the muscles and cause paralysis. Rhino will go to the epithelium of the nose, attach through the epithelial cells with the aid of the ICAM and cause the runny nose, which comes in form of the common cold. Kozaki can cause so many things. Can go to the brain and cause septic meningitis. It goes to the mouth and cause epangina. So this epangina is just presence of very painful ulcers, vesicles in the mouth. But which part of the mouth? They are present within the anterior aspect of the posterior aspect rather, the posterior aspect of the oropharynx. So it's quite different from the ulcer of this guy, type 1 herpes simplex type 1. So herpes simplex type 1 will cause gingival stomatitis. That vesicle that you have in gingival stomatitis, they are anterior to the oropharynx. But the one for Kozaki, when you observe the throat, you are going to see that the lesions, the vesicles are at the back of the oropharynx. So that's what you call epangina, mouth blisters, and there's associated fever. Then it can cause the hand and foot and mouth disease, where you have the lesions in the mouth, as well as the hand and the foot that we have talked about. So you have those lesions of this Kozaki, ulcers in the mouth, the fingers, and the sole. So once you are seeing that in the question, there's affectation of the mouth, the finger, and the mouth, the hand or the palm, and the sole. So in addition to consideration of secondary syphilis, you want to make sure that they are not actually tilting you towards Kozaki type A. If it's syphilis, you will know there will be some additional stuff that they will put there. But if it's only isolated to this hand, foot, and mouth, that is Kozaki type A. I think I've seen a question on that. So I think we need to look at questions to consolidate all these things we are learning. We should not just rush to finish them. Because if we keep rushing and we finish them and we don't know the relevance of them, of these stuffs to question, it will be like a futile effort. So I think we need to dedicate some time to be looking at questions one by one. So
Sorry, with Coxsackie virus, did you say that the hand, foot, and mouth is caused by a particular type? Is it A or B or is both?
yeah, A is more of A. We said it. We said it that A is in addition to the Rocky Mountain spotted fever and secondary syphilis, causing lesion affecting the mouth, the hand, and the sole. Do you remember?
Yeah, I remember the Rocky Mountain spotted fever. Yeah.
So the third one, apart from secondary syphilis, is Coxsackie type A. Dr. Oluwatobi checked it that day. Dr. Oluwatobi, are you there?
I can remember.
You can remember, okay. So
Mm-hmm.
we checked it that day.
Yes, I'm
And
here. Sorry. Yes.
yeah, so and in addition to syphilis, the third one was Rocky Mountain spotted fever. So once you see ant, foot and mouth lesion, you are thinking of Kozaki type A, not B. What is peculiar to
Okay.
B? Exactly. So what is peculiar to B is that it predominantly causes heart problems, pericarditis and myocarditis. Pericarditis and myocarditis. So myocarditis, they can say that somebody has a chest pain, he has fever, he has tachycardia, which is out of proportion to the fever. You know, that's one thing about myocarditis for you. Tachycardia is very mild. You are thinking of myocarditis. Then pericarditis, you know the way they will present pericarditis. So the person will be having pruritic chest pain, worsening with inspiration and all those things. Then you can hear the rub, you can hear the frictional rub, and the other associations with pericarditis, ECG changes, low voltage ECG changes, and all those things. So what I'm just going to say about this Kozaki is that type 1 and A can cause aseptic meningitis, but type A predominantly causes the epangina, which is the blisters in the mouth, in the posterior aspect of the oropharynx, as well as hand, foot, and mouth disease. And it can also cause myocarditis and pericarditis. So A can basically cause everything, but B is majorly for heart problem and the aseptic meningitis. The B doesn't cause the hand, foot, and mouth disease. It's more for A. A is what is predominant, for the hand, foot, and mouth. Just like B is predominant for myocarditis and pericarditis. Then the last one is
Is there any other organism that causes hand, foot, and mouth?
yeah. So Dr. Francois, that's what we are saying. When we are talking about those three guys, we said secondary syphilis, Kozaki, and Rocky Mountain fever. Now, secondary syphilis can present that way.
Um,
Do you understand?
okay,
Because
okay,
secondary
okay.
syphilis
Yes,
causes
yes.
a generalized rash. You know, it causes generalized, it can be anywhere, even including the palm and the sole. The reason why we are emphasizing that palm and the sole is that most of the rash in the body don't they spare the hands and the sole. They spare the palms and the sole.
Mm-hmm. Mm-hmm.
But
Yeah.
the ones that are notorious for affecting those guys is those three that we have talked about. So, but I am sure that secondary syphilis can cause hand, foot, and mouth as well as Kozaki A. So that is that. So syphilis and Kozaki A can cause hand, foot,
Thank you.
mouth
I get it now.
disease.
Yeah.
So the
I think
fifth,
my question now is which organism causes the Rocky Mountain spotted fever?
yeah. So Dr. Zulia, do you want to help us with that? If you can remember,
That'll be the
R,
is it
R.
rickettsia?
Yeah,
Rickettsia.
Rickettsia
Crickets. Yeah.
rickettsiae.
Okay.
So that's
Okay.
the
Okay.
code. Rocky Mountain spotted fever. R. Rocky. So you just add the
Thank
R
you.
to the Rocky Mountain to the what? To the rickettsia. So rickettsiae. Okay,
Thank you.
you're welcome, Dr. Francois. So hepatitis A can cause viral hepatitis, acute viral hepatitis. So this person can have abdominal pain, can have jaundice, can have hematuria, you know, and other features like that. So they can transmit hepatitis A fecally, they can get it through sexual contact, exchange of body fluid, and all those things. So that's that about hepatitis A. We are going to talk more about the hepatitis when we get to the hepatitis section. We are going to break it down very well. So the next one is the epi. The epi is also one of those guys that we said is not about enveloped. And the only organism that is in the epi is hepatitis E. And one thing just to note, to take home about hepatitis is that it's also transmitted just like hepatitis A, fecally, sexual transmission, transplanted, no, okay, sexual transmission. And one thing about it that they like to ask is affectation of pregnant women. So once this guy finds his way to pregnant women, it causes fulminant hepatitis. That hepatitis will be very, very severe, very life-threatening. So once you see fulminant hepatitis, pregnant women, the implicating organism is most likely to be hepatitis E. Hepatitis E. Um, Calisi, is one of those um, non-enveloped, and the only guy that is there that is worthy of notice is norovirus. So norovirus can cause
Doctor, But Baba, please, I think I actually missed. You said hepatitis E causes fulminant what?
Fulminant hepatitis. Fulminant hepatitis.
Okay,
Hepatitis that's very
hepatitis.
life-threatening.
Okay,
That is life-threatening.
okay.
That can almost kill that patient. God. That can almost kill that patient, particularly in pregnant women. Yeah. So, Calicium is norovirus. It causes viral gastroenteritis, just like Rota. So, if you are seeing the option, viral cause of gastroenteritis, noro is one of them. So, noro is one of them. It causes watery diarrhea too. That's just about noro, watery diarrhea. Flaviviruses. Okay, so this one it might be difficult to master, but I'm sorry, I don't think I have a code for it. So, high definition HD um WYZ. So WYZ and HD. So for the this flavy thing means yellow. So flavy, yellow color. So you want to remember the first two: hepatitis C and yellow fever. Hepatitis C, yellow fever. Hepatitis C, yellow fever. Then the other ones: dengue, West Nile, Zika. So if you remember the HDWYZ, it will be complete. W for the Western Nile, which brings about meningeal encephalitis and flaccid paralysis. I think, okay, we've not seen the question on this. So once you see demonstration of encephalitis, so that was the reason why that answer that we picked that day, although we got the answer right because it's an arbovirus, just like chikungunya, you know, but that organism that day wasn't Western Nile. I hope you guys remember the question I was talking about. That answer that we picked
No,
them.
no, I don't remember.
Ah, there's one question like that we picked mosquito-borne infection. That was the last option E. But I was thinking it was
For the West now.
yeah, for the that was think we were thinking is West Nile, but it's not West Nile. It's actually chikungunya. Okay, you guys don't
I
remember.
remember the chikungunya, yeah,
Exactly.
question.
Mm-hmm. So in that question, there's nothing like meningoencephalitis. So I think it was more of joint pain, fever, arthralgia, rash. I think that was what was there. There was not. So once you see that's
Yeah, and then I think lymphadenopathy.
yeah,
And then
lymphadenopathy.
there was lymphopenia or something like that, or lymphocytosis or something.
Okay. I can't really remember again. Yeah, so
Yeah.
so Western eye is just more like polio. It looks like polio. They both cause asymmetric flaccid paralysis. So there's flaccid paralysis in both of them. Polio can also cause encephalitis. So, but there will be a way they will, paint the question. That's why we need to look at question to see, how we can differentiate all these things. But Western eye will be transmitted by mosquitoes. The person will most likely be staying in an area that is um, full of mosquitoes, maybe Africa, Asia, and all those areas where you have mosquitoes, like particularly the Aedes mosquitoes that can transmit this Western eye. So the person will be having symptoms of, meningeal encephalitis as well as asymmetric flaccid paralysis. So once we see those two things, we should think of Western eye as a possibility. As a possibility. So dengue too, we are going to talk about dengue properly. So we are going to talk about dengue. Dengue, okay. Oh, how am I even moving? Let me start again. So hepatitis C. Hepatitis C, we know how hepatitis C will present. So we talked about hepatitis before. The person is having jaundice. And one thing about hepatitis C is that it has a very high chance of progressing to chronicity. That's one thing about hepatitis C. There's a very high chance the person is going to, you know, have the hepatitis C causing a chronic infection. Very, very important. And you don't typically get it through sexual contact. It's not commonly gotten through sexual contact like hepatitis B. Hepatitis C is majorly gotten through parenteral stuff. Maybe you are sharing needles or there's blood transfusion containing this guy. Parenteral. That's the most common route compared to hepatitis B, which is sexual. Yellow fever. So yellow fever is one of those flavy, is yellow. Hepatitis C causes yellow jaundice, so it's one of those flavy. Yellow fever too, the yellow component put under flavy. So yellow fever can, cause yellow fever. So because it predominantly affect the liver, they can be jaundice. So the person will be yellow and it affect the coagulation cascade. So it causes coagulopathy. So they will have bleeding from the nose, bleeding from the stomach, bleeding from the small intestine, which brings about a black vomitor. So if you see a question talking about somebody that traveled to an endemic region, maybe somewhere in Africa, and where yellow fever is endemic, and the person started having high grade fever that is very, very terrible, with vomiting of blackish substances, yellowing of the eyes, you are thinking of yellow fever as a diagnosis. Very, very important. Dengue. So dengue too is just one of those viral hemorrhagic fever. That's why it is very hard to separate those viral hemorrhagic fever unless you do your PCR test. When you do your reverse transcripted PCR, you can know the implicating organism. I don't know if our centers, if we make a diagnosis of any of these guys, any of those VHF, we usually query it. Very query. You can't say that this is dengue. You can't say this is Ebola. You can until you do your analysis. That's when. So because their presentation is quite similar. But dengue has a spectrum. So there can be dengue fever, there can be dengue hemorrhagic fever, there can be dengue shock syndrome. So the basic presentation for dengue fever is just fever, there's rash, there's arthralgia, there's myalgia. So it causes fever because of an infection. That fever is associated with a rash, a maculopapular rash, and there is affectation of the joints as well as the muscle. So there's myalgia, there's arthralgia. Then in addition to that, there's neutropenia. So dengue fever affects the white blood cells. So it destroys the neutrophils particularly, and there's neutrophilia with the fever stage, like the dengue fever stage. So as it progresses, it can cause dengue hemorrhagic fever. So by that time, it's now going towards destroying the platelets. So there's thrombocytopenia. So and when there's thrombocytopenia, the next thing that happens is bleeding. So there's bleeding. So the bleeding occurs in the skin as small petechial areas. You can see like petechial areas all over the body. And in addition to destroying the platelet, it also destroys the endothelial cells of the capillary. So there's extravasation of fluid from the vessels into the tissues. Now, all this can cause, so many complications, and one of them is shock. Just imagine when there is too much extravasation of fluid from the intravascular space into the extravascular space. There's no longer effective circulatory blood volume in the vessels again. So the person can go into shock because there's reduced perfusion to the organs. So when there's circulatory collapse from the excessive extravasation of fluid, due to the hemorrhagic presentation, the person can go into shock. So we call that dengue shock syndrome. So someone that has a dengue hemorrhagic fever and the person is bleeding, they can have, of course, the bleeding, like we said, is due to thrombocytopenia. So there's a low platelet count. Already, the person that's having dengue fever, it will have destroyed the white blood cell count. That is even contributing to the fever because you don't have anything to fight the infection again. So there's a neutropenia, there's thrombocytopenia that is causing the bleeding. The viruses are also destroying the epithelial cell, the endothelial cells of the capillary, causing a circulation of fluid. Fluid is moving out of the plasma is moving out of the intravascular space into the extravascular space, causing something like look like edema. So all these things can even, dilute, the red blood cells in the intravascular space and cause an increased hematocrit. So you can have two spectrum. You can have increased hematocrit or anemia. So anemia is okay, maybe when there's too much bleeding with respect to the extravasation. If the bleeding was too much, the person will go into anemia. You have anemia. But if the extravasation is actually much, you can have hemoconcentration. So the person can have high hematocrit. But two things are constant. There's neutropenia and there's thrombocytopenia. So that's that about dengue. Western Nile,
So, I have a question. Sorry, please. What did you say causes the thrombocytopenia?
it destroys the platelets. So it destroys the
So
platelets.
it destroys both the platelet and the white blood cells.
Exactly.
Yeah.
It destroys both the platelet and
Okay.
white blood cell. Yeah, that's correct. So it destroys both the platelet and the white blood cell. Cause those things. Then Western Nile, just like polio, meningoencephalitis. We said polio can be a cause of aseptic meningitis. In addition to polio, echovirus is also a cause. Then the last one is the Coxsackie A. So polio and Western Nile can also cause meningoencephalitis, and it can cause acute flaccid paralysis, which is asymmetric. So the paralysis will not be symmetrical, just like polio. Zika virus is the last one. So Zika virus too, the triad of Zika virus is an infection. There's a fever. There's a rash, you know, there's uh there's lymphadenopathy, there's arthralgia. But what is very common with this Zika is the congenital Zika syndrome. That's what they typically ask. So it typically causes because it can be transmitted sexually as well as transplacental. So if it moves from a mother that is infected to a fetus, it can cause congenital Zika syndrome. So what you typically see is a baby that has MOM. So MOM is the acronym. So microencephaly, they have a very small head. They have ocular abnormalities. They can barely see because there's ocular problems like optic nerve atrophy. There's atrophy of the choroid layer as well as the iris. So as well, even the retina. So there's atrophy on almost all the high layer. So it causing visual problems. You can have, problems with hearing too. You can have sensorineural deafness. They can have that's the MOM. So the first M is talking about the microencephaly, the small head. The second M, okay, so let me go. So the first M, microencephaly, the O, ocular abnormality, like optic nerve atrophy. The third one, which is the M, the last M is muscular problem. So they have muscular problem like seizures, they have spastic paralysis. So that's that about congenital Zika. So don't forget, we'll talk more about it, we'll get there, we'll talk about it. So toga, the only organism that is very, very important.
Dr. What is the difference between the Zika, in the manifestations too, and the chikungunya?
Yeah, so they have similar stuff. They are very similar. Those guys are very similar in their presentation. They don't have anything that distinguishes them. The only thing I can just say about chikungunya is that chikungunya causes chronic arthritis. So one of the ways they can, pinpoint chikungunya is the arthritis that it causes. There's a very, very chronic arthritis with
Like the
chikungunya.
severe arthritis kind of thing, Abi?
Yes, yes. There's a severe arthritis with chikungunya. So it causes fever, it causes rash, maculopapular rash, lymphadenopathy, then the arthritis. Chikungunya doesn't cause bleeding. Once you are seeing bleeding, don't think about chikungunya. Take your mind to dengue. Dengue is the one that causes the bleeding. Zika itself, no, they cause bleeding. So bleeding, you are thinking of dengue. Dengue is the only one. So we go to the toga. So for the toga, that's where the chikungunya lies. So once you remember toga, toga is chikungunya. Toga, chikungunya. Forget about rubella, forget about this Eastern, Western, equine encephalitis. Nobody will ask us, but you can know it. So the organisms in the toga class is krill, although they have removed rubella from toga. Rubella is not part of Mantona, not toga again. So I don't know why they are still putting it here. Maybe just to make it complete. So krill, because rubella is formerly there. So C is for the chikungunya, R is for the rubella, E is for the Eastern and the Western equine encephalitis virus. So, but I think the take home here is actually chikungunya. Chikungunya is toga. And we have said how chikungunya presents fever, lymphadenopathy, the rash, maculopapular rash, and arthritis. Later, the arthritis will become chronic. You have this chronic jumping that is unresolved. That's that about chikungunya virus. It's also transmitted by Aedes mosquito. So Aedes mosquito bites somebody, they inoculate the virus into the body, and it can cause the chikungunya manifestation. Mantona, rubella. So rubella is very easy to palm. Rubella is also known as German measles, and we already talked about. Did we talk about how measles present? So we said measles present as, I think I said that to Dr. Francois yesterday. Dr. Francois, is that right? I think we talked about measles yesterday.
Yeah, you did.
So like the rash typically start from the head, move downwards to involve the limbs and the trunk. So that's that about measles. So the same thing for rubella. It starts from the head and move downwards because rubella is also known as German measles. So they have the same presentation. So once you see that particular distribution of rash, and we are seeing lymphadenopathy, particularly posterior cervical lymphadenopathy. Lymphadenopathy at the back of the posterior auricular rather. Post-auricular. Which one is posterior cervical? Anybody?
See?
Eh?
Yeah. That's CMV. I'm not sure.
CMV care. It's not CMV.
Yes,
You said everything about
Okay, the one that affects the
I was going to say
EBV.
Epstein Barr.
Epstein-Barr, yeah, nasopharyngeal carcinomas
Exactly,
on the line.
exactly. Epstein-Barr,
Mm,
infectious mononucleosis, infectious
yeah.
mononucleosis.
Burkitt lymphoma.
Exactly. You know, so rubella is not posterior cervical; it is post auricular, just behind the hair. So once you see somebody having fever, having post auricular lymphadenopathy, the person having maculopapular rash, a fine a very fine maculopapular rash that is starting from the head, moving downwards with arthralgia. My sister, my brother, that is rubella that they are trying to, make you see. But rubella will most likely come in form of the congenital form, because it can be transmitted congenitally, transplacental. So it can affect the newborn, and the person will have the congenital syndrome, the congenital rubella syndrome, which includes, do we know it? Congenital rubella syndrome. Do we know it?
The
There should be
PDA,
cataracts,
the
Cataract,
cataracts,
cataract,
the
deafness, right?
deafness.
sensorial deafness,
Deafness, yeah.
microcephaly sometimes.
There's something with the heart,
Um,
oh?
Yeah. So what's in the heart?
PDA,
What's in the heart?
Yeah, Dr. Azulia just
the
said it. PDA.
PDA.
There's a PDA in the heart. That is it. So there's a PDA in the heart. There's sensorineural deafness. There's cataract. They can have other findings too. We call something blueberry muffin. I don't know if you guys have heard of it. Blueberry muffin rash. So
Yeah.
that blueberry muffin rash. Me, I don't emphasize it again because it occurs in almost all of those congenital infections. So if you just look at the baby, you are seeing some purplish lesion on the face, on the body. That's the blueberry muffin rash. So it's just due to um extra medullary hematopoiesis. So you're having hematopoiesis within the dermis of the skin. That's the reason. So there's increased blood production within the dermis of the skin in them. So that's what brings about that classic presentation of that rash. It's because of increased um, extramedullary hematopoiesis in the dermis. So it's not occurring in the bone marrow, it's now occurring in the dermis of the skin. All of them, almost all of them have it. So it's not one of those classic, you know, stuff finding. So the retroviruses have reverse transcripted. What other organism have reverse transcripted aside the retro?
Hepatitis B.
PDA.
Hepatitis B. Thank you, Dr. Toby. Hepatitis B. So the two viruses that we have in retro family include HLV, which is human T leukotropic virus, and HIV virus. So human T leukotropic virus can cause T cell leukemia. So they have adult T cell leukemia and HIV/AIDS. So that's that. Corona, causes spectrum, common cold, the severe acute respiratory distress syndrome, COVID-19, and the MERS. So automyxo influenza, this one is very important. So we are going to talk more about influenza as we move. So influenza can cause flu. So this person will just be having runny nose, they'll have fever, there's a cough, there's sore throat, there's malaria, normal constitutional symptoms. But the runny nose will be there, flu. And one thing I want you guys to take home with respect to influenza is that it can cause pneumonia. But the pneumonia from influenza will be one of those atypical pneumonia because the virus is not from strep pneumo. So this will be atypical pneumonia. And the pneumonia from influenza infection can be from the virus itself or from a superimposed bacterial infection. So bacterial infection can settle in,
Staph aureus.
which is Staph aureus. But it's not only Staph aureus, but once you see it in the question, please go for Staph aureus. But if it's not Staph aureus, it can be strep pneumo or Haemophilus influenzae. So I like that. I like what Dr. Oluwatobi said. Staph aureus should be what should come to our mind first. So that is the approach I want us to be giving all these things. We should be knowing the first one in line, you know, the most important one before we talk about the other ones. So Staph aureus first, superimposed infection. So if someone has influenza, you are open to have secondary bacterial infection, and that one that complicates it, Staph aureus. Then strep pneumo can also come in influenza and they can cause pneumonia. Then this guy typically uses some factors to enter the cell. That's where they can start testing us. So it uses two things. It uses hemagglutinin on its protein coat. That's hemagglutinin and it has neuraminidase. So the function of hemagglutinin is just to bind to the epithelial cells. It uses that hemagglutinin to bind to salicylic acid. So there's something called salicylic acid on the epithelial cells, more like a glycoprotein that allows interaction with the M-agglutinin so that it can enter the cell it wants to infect. Now, when it now enter that cell, if it wants to replicate and release the viral progeny, what does it use? It uses a neuraminidase. So neuraminidase is the second one after the sorry, excuse
Shigella. No, Salmonella and Shigella, you
And
need a large inoculum of Shigella, but a small inoculum of. No, you need a small inoculum of
no,
Shigella, but a large inoculum of
inoculum of
Salmonella.
salmonella.
exactly,
Yeah.
exactly.
Salmonella does not need plenty, but Shigella, the tiny one, will kill somebody.
Even Vibro too. I think the inoculum stuff you need a large percentage of it. I
But
thought it was for it.
Yeah,
Shigella is
because of the
For the
gastric
most
Vibro.
of
acidity.
all of them.
Because of the gastric acidity, yeah.
Yeah.
Okay, so
Because of the what?
the gastric acidity, so that you can have a number that can bypass the
Okay,
gastric acidity and go to the
okay,
intestine.
okay.
Yeah, so that's that about the rhino. They get destroyed by the gastric acid. That's why they don't cause any GI tract infection. So rota can cause gastroenteritis across the world. So it can cause global infantile gastroenteritis. Once you are seeing children, you should be thinking of rota. It's very common where you have people close together. So in daycare centers, in kindergarten, where the babies are together, they can easily infect themselves with the rotavirus and get the infection. How does it cause the watery diarrhea? It causes venous destruction with atrophy, which leads to reduction in the absorption of sodium and eventual loss of potassium. So another thing that also works this way is the enteropathogenic E. coli, as well as this guy, cholera. So cholera also destroys the villi. Enteropathogenic destroys villi. Rotavirus also destroys villi. I've talked about this as you want to give infants this vaccine, the live attenuated vaccine of rotavirus, but you don't give it in people with history of deception and SCID. Influenza virus. We've already talked about influenza virus very well. We said it's one of those envelope virus, and all of them are enveloped already, except that's the way to always come about. If you want to figure out those things, you might not be able to say spinal nerve, but just go back to the mechanism. We said all of them are enveloped except the first three, the first four, which is a patch. So you use that one to know the ones that are enveloped. Then you can figure out the other peculiarities. So of course, it's one of those segmented one, and it contains two protein, M-agglutinin and neuraminidase. You use M-agglutinin to bind to salicylic acid. Bind to I'm always saying salicylic aspirin. So it binds to salicylic acid on the epithelial cells, and that can promote viral entry. And it can also attach, to the cell and release the progeny by the activity of the neuraminidase. So neuraminidase is more like a cleaving enzyme. So that enzyme will just help it cleave off the progeny so that they can, cause, other infections that they want to cause. So just release the progeny and keep the infection going. That's the activity of neuraminidase. So it can cause superimposed bacterial infection. I've talked about the three organisms, Staph aureus, Strep pneumo, or influenza, but most commonly Staph aureus. Treatment is supportive. You just want to give fluid, you want to give analgesics, you want to give because the person can have sore throat. You want to give uh you know drugs that can help with the sore throat, and some people use throat spray or something. Yeah. So then you want to add neuraminidase to that to prevent reinfection, and also to reduce the incident of the ongoing infection. So you want to reduce the severity of the ongoing infection, you can add your neuraminidase depending on the severity of the infection. So you can give the oseltamivir or zanamivir. So both of them are neuraminidase inhibitor, which prevents release of the virus, not preventing entry. Entry has already occurred. So you just want to prevent it from releasing subsequent virus by giving your neuraminidase. So there's something we call the reformulated vaccine for virus for influenza. So developed countries have adopted this method to prevent outbreaks of the influenza. So what they do is that when there's an outbreak now, once it ends, they try to collect the strains of that influenza that is involved, because that outbreak is usually caused by so many strains at once. So they try to collect the the strains that are involved in that particular outbreak and develop vaccine containing the strain that they think will likely cause another outbreak. So it's more like a prediction. So it's not entirely effective because influenza is subsequently undergoing genetic change. You guys remember when we talked about reassortment? And we said reassortment is just like you are having infection of a cell by two different strains of a virus, and those strains are mixing together, they are mixing their genome together to form an entirely different strain, an entirely different virus that you have altered that genome completely, and the protein that that virus is going to be elaborating will be quite different from what you are used to. So you always want to make sure you are collecting that information like that, and you are, developing a vaccine that can unify all those strains together. So it might work, it might not work because you can't put all the viruses in the strain. Even if you do so, there's possibility that the next outbreak is going to be caused by another strain that's not included in the vaccine. So it's not 100% effective because um you try to predict that, okay, out of all the strains that have been causing influenza outbreaks, let us select this one, this one, this one, put it in a vaccine and give people, and hope that that is also the one that will try to cause the next outbreak. So if those viruses are involved in causing the next outbreak, they will be prevented. But if new strains develop and they attack people, they will not be protected. So the outbreak will continue happening. So what they do is that they do it every year. They do it every year. So they do the reformulation every year. So, but there are two basic forms of vaccine for influenza: the killed and the live attenuated. The live attenuated is the killed one is the one that we give intramuscularly. So it contains the killed form, while the live attenuated one contains the one that has been subdued. So that's the one that you give intranasally. So because the nasal temperature can favor its replication. Once it gets into the lungs or gets into the body, it dies. It becomes inactive. So the antigenic response is more when you give it intranasally and it stays in the nose. So that's that about influenza. I hope we understand the concept of this reformulation. Hello?
Hello. Partially, sha. Hello.
Yes, I do. So it's basically that, okay, that strain that is causing the antigenic drift, since there are a lot of them, so they'll collect it and then use it to kind of like produce one that can destroy the next one that they think that they are predicting might cause the next outbreak. Abby?
Exactly. Because there's antigenic shift. That means that you have so many strains.
Antigenic, is it shift or drift now?
Shift.
The SIP is one that is in so many
Shift,
organisms,
okay.
Abby.
Like,
Thank you.
yeah.
Thank
No,
you.
the thing is, both shift or drift, any one of them, both of them are shared with change in the antigen. Do you guys get any one of them? It's just that
Yeah.
the problem with shift is more massive because in shift you are producing like a entirely different virus. Because in shift you
Oh,
are changing the
okay.
genome. In 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 in
Okay. Okay.
in 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 drift, you
Drift.
know that drift is just mutation. I said it that day. It's just mutation in part of the genome. So part of the genome that is encoding the receptor is what is affected in the drift. So it is only maybe in one strain now, it's only that the neuraminidase receptor is affected. The hemagglutinin receptor can be normal. So
Left alone.
the antibodies that you are developed towards the previous one may still work or may not work. So um drift doesn't usually cause pandemic. The worst it can cause is epidemic. Do you guys get it? So the change in the
Okay.
genome for drift is not massive. It's just you are just mutating a segment of the genome. You are just mutating a segment, and that segment is the one that is coding for the receptor. You guys know that it is a receptor, the antigen, that is determining the immunogenicity, like what is going to infect, how the antibodies
Mm-hmm.
respond to them. You guys get that?
Uh-huh.
But in the shift, you are changing the entire genome. Like you are mixing one
Entirely.
you are mixing one genome with another genome because you have two viruses that are infecting a particular cell. Do you guys get? Two viruses are
Yeah.
infecting a cell. They will mix together.
Is that like the phenotypic mixing something?
No.
Oh, that one is okay. I remember. Don't
This
worry.
is no. You don't need to tell me I should not worry. I'm going to
Is
explain.
not is it
That's why
not phenotypic reassortment that is going on in this one?
if you don't know, Dr. Juliet, that's why I'm there to explain to you. I'm not going to get angry because you don't know. So if you have two viruses infecting the cell, those viruses will mix together and they will share their genome and they are going to form new strain entirely that is containing a blend of those genome. So you have changed that genome entirely. So it's going to form a separate virus entirely. That's why they are saying if virus A is the one that infects pig and virus B is the one that infects human, they are going to make a new strain that can infect cattle. Like that
Mm.
is it. And that one that can infect cattle will continue spreading like that and be infecting cattle like that continuously without stopping. How you separate that from phenotypic mixing is that in phenotypic mixing, you are not changing the genome. You are not. What you are just doing is that, okay, virus B, you can affect cattle, Abi. Me and virus A, I can affect human. Now, I want to be infecting cattle too. What do you want to do for me, virus B? Virus B will now donate its protein code to virus A so that virus A can now, because that's what we call tropism. The kind of cells that they affect is determined by the protein code that they possess. So,
Mhm.
hello?
I'm with you, Dr. Baba. I'm getting
So,
you.
so the virus A will now receive the protein codes from virus B, so that it can also infect cattle. But you know that when virus A now infect cattle, when it proliferates, it is the genome that is proliferating. So that means that when it proliferates and give rise to a progeny, because of the fact that the virus A still contains its own genome, it's just the protein code of virus B that is with it, so that it can infect cattle. Once it infects
Mhm.
cattle with that protein code, it's going to replicate, and when it replicates, it is the genome that is going to replicate. And
Yeah.
it is the protein that its genomes encode that is going to form in the next progeny. So those progeny will not contain the protein code of virus B
Um,
again.
okay.
You now notice that those progeny will not be able to infect cattle. You get.
Okay.
So that
Okay.
is that
Okay.
is how you can separate phenotypic mixing from the assortment. If you notice that that change that they are trying to acquire is not long lasting, is not passed to the generation, that is phenotypic mixing. It can
Phenotypic
only
mixing.
it can only benefit that present virus. Once that virus replicates, it's not going to replicate with the protein code. No, it's going to replicate its genome, and there's going to be protein synthesis from the genome, and the protein that is going to synthesize will be its own protein, not the protein from virus B. So the progeny will be having protein codes from its own genome, and they will lose ability to infect cattle. But if it, what's it called? If it
Yes.
reassortment, those guys have combined their genome. They have already formed a new genome. So once they replicate, they will keep transferring that genome to other progeny. So the effect of
Mm.
that genome will stay with them for life.
Whatever.
Do you understand the difference between phenotypic mixing and reassortment now?
Yes. Yes.
So that is what you must always look out for in the question. Is the effect long lasting? Does it get transferred to the progeny? Now, I would like you to try and go back to the page and look at the questions that we solved. There's a last question that we did, and we picked phenotypic mixing. The reason we picked phenotypic mixing was because the progeny could not perform the function that the mutant virus was doing again. The progeny could not do it because they don't contain that protein code again. That is it. Okay, so let's go back to the shift
Thank
and
you.
yeah, you're welcome. So let's go back to the shift and the drift again. So when we are talking about the shift, that's the reassortment,
No, Baba, you said you pick which answer?
phenotypic mixing.
Okay.
So it's two questions, Dr. Lushola. We did like 4 questions. We picked
All right.
reassortment one, we picked phenotypic mixing somewhere. So if you look at the shift, you are mixing the genome. Two different strains infecting one organism, they are mixing genomes. So that means that the viral change is going to be massive. It will be very difficult to control. So that's why it results in pandemic. You are going to be producing a separate virus. But in genetic drift, that one is due to the fact that that virus has been existing, and of course the virus will be replicating, and as it replicates, they are acquiring a mutation. So if the mutation now affects the segment of the genome that encodes the outside protein, which includes the neuraminidase that it's used to infect, or hemagglutinin, so it can cause a problem because your antibodies that have already been developed may not be able to respond to that to those antigens again. So it might be difficult to control, but it's not very severe because the change is just minor, it's local, it's not changing the genome, it's just changing the outer protein that they express. So the antigenic change is minor, but the antigenic change in our shift is major because the entire genome is changing, the entire protein is changing. But for the antigenic drift, it's just part of the protein that is changing. Maybe neuraminidase is changing here, and then another one, hemagglutinin is changing, and the change is not very severe because it's just a slight mutation. So you can see here in the statement here, thank God they even put it here, minor changes in the protein for hemagglutinin or neuraminidase. The antibody might not be able to respond to it, but some might respond, some might not respond. So because of some that are not responding, those are the ones that can cause epidemic. You know, that is that. And that's just what I want you guys to pay attention to. The more severe the mutation is, the larger the spread. So if it's a very severe mutation like in the shift, pandemic. If it's just minor mutation in the protein, epidemic. So before they can quickly develop new vaccine against that protein, and they can take care of it before it spreads globally. So when they see that, okay, there's a minor change in the hemagglutinin, they will look at the strain, they will quickly develop antibody against it to stop it so that it doesn't spread beyond the country. But to control the one that you have changed the entire genome is very difficult. It's very difficult. So that one has a high chance of spreading across the country. So rubella virus is a Mantona virus. It's not part of the TOGA. We have removed it from TOGA. TOGA is now, what's the acronym for TOGA? For TOGA. Do we remember? Acronym for TOGA. Okay.
So that crew. Just remember
It was crew.
Oh, CEW. You said we should remove the R. Is it the one with the chikungunya, the E and the W? I can't remember that one. Maybe the West. No.
Yo, so what did you say, Dr. Zura? Let me see where you are getting it difficult. What are you saying?
I said that you said we should remove the R. So it's CEW. So the chikungunya I remember, but the E and W I couldn't remember.
Yeah, so the Eastern and the Western equine virus, it's because I said we should just delete, it's not important. Eastern and Western equine virus. So those are the most important one is what you have remembered, which is chikungunya, is a TOGA virus. So Mantona virus, rubella. Rubella is German measles. What does German measles cause? We've said it initially. Fever, our post-auricular rash, the arthralgia. And you can see the distribution of the rash is starting from the face and moving downwards centrifugally. You guys can see that it's not hard. Once you can remember that German measles, which is rubella, is also measles. Both of them follow the same distribution. Start on the face and move centrifugally to the trunk and the extremity. You are okay. Then you just need to remember the other ones, which is the post-auricular lymphadenopathy. That's one of the classic findings. And the arthralgia. That is it. You are done with rubella. Then it can be part of the touch infection that causes the classic triad of sensorineural deafness, the cataract, and the PDA. Then the blueberry muffin that we talked about, which is due to dermal extramedullary hematopoiesis. I think you guys should be able to say everything about rubella. I've been at Dr. Zuliat. Is it hard?
I think it's put together. I don't think if this is what we need to do. So I think we should be able to do this. It's not.
Yeah, Dr. Lushola, you want to say something?
Rubella.
Dr. Lushola?
I say it's clear, very clear.
Yeah, so that's that about rubella. It should not be much of a problem. Then paramyxo. So we have some little details here. So paramyxo includes from the name, we just look at it, PRM. So paramyxo, PRM. So P for the parainfluenza, the R for the respiratory syncytial virus, the M for the measles and the mumps. M square, measles and the mumps. So what are those peculiarities? All of them can cause pneumonia too. They can cause pneumonia, and they can cause pneumonia, and para-influenza virus typically causes the croup, and we have said croup is what? Laryngotracheobronchitis. So there's inflammation of the larynx, the trachea, as well as the bronchial walls. So there's laryngotracheobronchitis, that is croup. And we said the typical way that the croup will present is what? The stridor, the inspiratory
Respiratory stridor.
Respiratory stridor.
and what?
The backache
Backy
cough.
cough. Backy
Mm.
cough. That is it. That is it. Then we said because the inflammation is happening in the trachea and the larynx, there's going to be narrowing of the trachea, narrowing of the larynx. That is it. So let's look at the X-ray. We call the X-ray steeple sign. So can you guys see this thing that is looking like pointed object?
Mm.
Hello?
Okay.
So this is it.
Okay.
This is a trachea, coming downwards. You can see that it's already narrowed. It makes it look pointed. So once you see this steeple sign, you know that this is likely to be croup. So we should remember the other X-ray features of the other ones. When we're talking about epiglottitis, we talk about endoscopic feature for epiglottitis. What did we say? Anybody? Do we
Thumb
remember?
sign.
Thumb sign. But thumb sign is on
Thumb
X-ray.
sign.
Thumb sign is on X-ray.
On X-ray.
For
Mhm.
endoscopy, you are going to see like inflammation of that. So it look like cherry red appearance, because of the erythema and the redness of the epiglottis. Yeah, so that's very good. Thumb sign. So all these guys, the parainfluenza, the mumps, the measles, the RSV, human metapneumovirus, they can cause respiratory tract infection like bronchitis and pneumonia. So that's it. That one is not high yield. All of them can cause that. So it's not something that narrows them. But what I just want us to remember is that all of them have F protein, which is a fusion protein. They have F protein. Now, they also have this neuraminidase and hemagglutinin, just like in influenza. So they have the hemagglutinin and the neuraminidase, so that they can also use that to enter the cell. So what will the hemagglutinin do? Hemagglutinin is the one that binds to the salic acid on the epithelial cells. Once they use the salic acid binding to enter the cell, they now replicate and release their progeny by the activity of their neuraminidase. Now, one thing that is now peculiar to these guys, in addition to those two things, is that they now have another thing we now call F protein. That F protein is a fusion protein. What it does is that it's as if the binding with the hemagglutinin is not enough. They want to further bind to that epithelial cell. What will they do? They will use the F protein on them that is elaborated from their own membrane to bind with the cell membrane of the cell. So it causes a fusion. So when the epithelial cells, fuse with the membrane of the virus itself, the viral membrane fuses with the epithelial cells, they form what looks like a giant multinucleated cells. So that is through the activity of the F protein. So F protein is just a protein that allows fusion of the viral membrane with the respiratory epithelial cell membrane, so that they can form multinucleate giant cells. You're having two cells now, cells of the virus, cells of the epithelial cell, forming multinucleate cell. Don't forget that. That's the function of the F protein. So you might want to give a monoclonal antibody because we've discovered the function of that F protein. So if you try to alter that F protein activity, we can curb the infection. So give palivizumab. So palivizumab is an antibody against F protein. What does it do? It can, prevent the fusion of that F protein with the it can inhibit the activity of that F protein, so that you don't have fusion of the viruses with the respiratory epithelial cells, and they can prevent pneumonia infection. So they typically use it to prevent pneumonia from RSV. So don't forget RSV, F protein because we have said it that RSV is the commonest cause of bronchiolitis in infants. I hope you guys remember that. RSV
Yes.
is the commonest cause. Please don't forget. RSV is the commonest cause of sorry guys, sorry, I'm very sorry. It's the commonest cause of bronchiolitis in infants. Please, guys, I'm so sorry. Okay, guys. Yes. So, um, that's that. That's that about the RSV. That's that about the paramyxo in general. So let's look at them individually. Acute laryngotracheobitis, that's the croup. We can see the steep sign. It's caused by parainfluenza. It uses the hemagglutinin that binds to salicylic and promotes viral entry and neuroambulas that we have talked about that so many times. So they have this characteristic bacchic cough and inspiratory stridor. There's narrowing of the upper trachea and the subglottis. So glottis is just the opening into the larynx. So don't get confused, just the opening into the larynx. And the cause is characteristic sign on X-ray. That is that. I think the next class, we are just going to be looking at questions on all those things that we have learned. So, measles. We've talked about measles. It's also known as rubiola. So please don't say roseola. So guys, there's a difference between roseola and rubiola. So what did we talk about with respect to roseola? What did we say at the peculiarities for roseola?
High fever.
Extreme temperature. It's
Yes.
RAS.
Yes.
It's HHV 6 and 7. Is
Fantastic,
it
Dr.
HHV?
Zuliat. Fantastic, Dr. Zuliat. What else?
They have, do they have
Erythema
seizure?
infectiosum.
I'm listening to you, Dr. Francois. You're saying something.
Okay, sorry, Dr. Zuliat, I interrupted you. I was just adding erythema infectiosum.
Erythema infectiosum is another thing. That's another virus.
That's this thing, no, that's parvovirus.
That is parvovirus. That's
That's
The slap
the fever can cause
disease is
seizure.
parvovirus.
that was like seizure.
Yeah,
They
please.
can
I want
have
you guys to
seizure from
remember
The fever
that.
can cause seizure.
Please, you guys should not remember the high fever only. That's not what you are going to see in the question. No. Following that high fever, when the fever subsides, even within that febrile phase, they can have febrile convulsion. That's the next thing you see. So, when the high fever occurs greater than like 40 degrees Celsius, they can have febrile convulsion. When there's a febrile convulsion, the fever can subside, then the rash now starts. So you now see the rash starting. So the rash starts, and the characteristic of the rash is, starting from the trunk, moving outwards. So it starts from the trunk, then move outwards. Then, that is that about the guy. So please, you guys should not forget that the rash coming after the fever. That's the most important thing. And the fever causing convulsion. Once you see a child convulsing and temperature is like 40, you want to think about roseola from 6 and 7. So rubiola is the third guy. It can cause the four C's, which includes the cough, the coryza, the runny nose, conjunctivitis, and Koplik spot. We said conjunctivitis is also peculiar to Zika. We should not forget Zika. So which other virus apart from Zika? Once we hear red eye, one virus will come to our mind. Red eye.
Adenovirus.
Thank you, Doctor.
Yes,
Adenovirus. Adenovirus is also one of the causes of red eye. You guys are learning it like that. Adenovirus, measles, then the last one is Zika. Zika. So, how does it present? You have those C's, then you now have the Koplik spot appearing subsequently. So you see bright red spots with blue-white center. You guys can see this red spot with the white center on the buccal mucosa. You see it in the cheek. You have to open the mouth. You look at the cheek. You see the red spots within the buccal mucosa. Then you see the maculopapular rash occurring subsequently from the head and neck, spreading outwards. So what are the peculiarities? Measles is a virus. You are going to have lymphocytic response to it. So we call something the Wartin-Finke Jann cells. So the Wartin-Finke Jann cells, they are just fused lymphocytes within the lymph nodes, and they are going to the T cell, because the lymphocytes that are particularly responding to them are the T cells. So they are going to fuse together and form these Jann cells that we call the Wartin-Finke. So it's one of those peculiarities of measles. So because of those proliferation, those aggregation, you are going to have paracortical hyperplasia. So what are the complications of measles? Before I go to this complication, I just want to mention that the commonest cause of death in people with measles is pneumonia. The pneumonia can come from the measles itself, and it can come from superimposed bacterial infection. We should not forget that it is pneumonia that kills them first. So it's one of the acute complications. These other ones are actually long-term complications. Subacute sclerosing panencephalitis, SSP, subacute, sclerosing, panencephalitis. So what just happens is that when the virus enters the body, it finds its way into the neurons and the glial cells. It stays there, but it cannot cause infection. It cannot cause infection in the glial cells. So when the primary infection of measles subsides, when it causes all these complex bulk coryza and it subsides, the virus can now reactivate in those neurons. So it can occur maybe after years, like maybe 20 months to 10 years later, it will now occur. So when it occurs, it's going to cause some neurologic complications because they're hiding within the neurons. So what are these complications? Because it's an encephalitis affecting the brain parenchyma, so they can have personality changes, they have behavioral problems. They are no longer behaving the way they used to behave. They have intellectual problems. Part of them is cortical function problem. Dementia is one of them. It can destroy the autonomic nervous the peripheral nerve. So they lose autonomic function. They cannot control their bowel. They cannot contain erection. They cannot, they cannot achieve erection. They cannot move bowel. They cannot control urination and all those things. Then later they die because it's fatal. They die. Another one that happens in 1,000 is encephalitis. So encephalitis is just like this. They can have seizures, they can have slur speech, they cannot talk, they cannot move, personality problems, encephalitis. Then in addition to that, they can form pneumonia. They can also cause pneumonia. But this pneumonia will be having some characteristic cells. So you'll be having fusion of the monocytes to form giant cells. So those monocytic fusioning are going to be seen within, the alveolar cells. They are going to, oh my God. It's going to be within the alveolar cells. Sorry guys, just 1 minute. Just 1 minute. Okay. Yeah. Yeah. So that is that about the pneumonia. So they can cause giant cell pneumonia symptoms. But if you do the biopsy of the lung, you are going to see formation of giant cells within the alveoli. They can cause encephalitis and they can cause SSPE. So, but just the most important thing to actually remember here is not actually these long-lasting guys because you rarely see them. The most important thing to remember is that the commonest cause of death in measles is superimposed infection. Measles causing pneumonia or the pneumonia caused by superimposed bacterial infection. Isha pneumonia, very important. And what is the drug? Because there's no drug to treat measles. What you just give is supportive treatment and you give vitamin A. So vitamin A has been shown to reduce the pathogenicity of measles and to prevent recurrence of the measles. So you have vitamin A in actually prophylactic dose and therapeutic dose. So yeah, I can't remember the dose now, maybe 1,000 or 10,000 units, I can't remember. But you have it in therapeutic dose that you give to treat measles infection, to subdue that infection, and you also give a dose that can prevent future occurrence. So vitamin A is very important for measles. Please don't forget. Vitamin A is important for measles. Vitamin A, that's what you give. You don't give any antiviral, it is vitamin A. We have talked about mumps. It's now uncommon because of the MMR vaccine. So we have the mumps, measles, rubella virus. So that can help us take care of those guys. So they are not common like that again. But they typically cause parotitis, orchitis, aseptic meningitis, pancreatitis. So we've talked about it. So it can be a cause of sterility after puberty. So if they tell us that somebody has a history of swelling of the neck in childhood and suddenly became sterile, you guys know the diagnosis already. I've been now, guys. We know the diagnosis. That's likely to be mumps virus infection.
Mumps.
Yeah. So, okay. So let's talk about we stop here. The arboviruses, from Aedes mosquito. So arboviruses are just viruses that are transmitted by insects. And what's the insect here? mosquitoes. And what's the mosquito that is common? The Aedes mosquito predominantly. So we are going to be comparing and contrasting chikungunya. So both of them can present similarly, although dengue is more severe. You'll be seeing hemorrhagic symptoms in addition, and both of them belong to different class. So dengue belongs to the HDWYZ class. HDWYZ class, which is the flavivirus. HDWYZ class. I mean, our guys, that's the code that we just try to give it. And chikungunya is the toga, the crew toga. So toga virus and flavivirus. We also call them the alpha virus or toga, alpha or toga. So dengue is flavi. So what's the classic presentation for chikungunya? There's going to be fever, the maculopapular rash, constitutional symptoms like headache, lymphadenopathy, and arthritis. So arthralgia, you can see joint swelling is more specific for chikungunya. Once you are seeing swelling of the joint with arthralgia, you are thinking more of, and no bleeding, although it can cause thrombocytopenia and leukopenia, but they don't typically bleed. It's very unusual, and I'm not sure the question will want to give you hemorrhagic situation to confuse you, because it's not something that is common, so they will not put it there. If they want you to make diagnosis of chikungunya, they will focus more on the fever, the rash, as well as the lymphadenopathy with the inflammatory polyarthritis. So they are going to be having this chronic arthritis. That's what separates your chikungunya from your dengue. So dengue is a flavivirus. It has 3 spectrum: the fever, dengue fever, the dengue hemorrhagic fever, as well as the dengue shock. So they have removed, okay, the shock is there. So for the fever, you just have the fever, just like in chikungunya. They have the rash, maculopapular rash too. There's headache, there's myalgia. They can have arthralgia too, and retroorbital pain. Yeah, very good. You can have this retroorbital pain too in Zika, You can have it in Zika, but it's good to pay attention to the neutropenia that you have in the fever. So there's a fever, there's a headache with shared neutropenia. That's the dengue fever. Then the hemorrhagic fever now occurs when there's affectation of the platelet. So it causes severe thrombocytopenia, brings it down to as low as less than 50,000. That's going to cause severe bleeding. So bleeding happens. So hemorrhagic fever is when you have the fever, all the symptoms of the fever, headache, arthralgia, and all those things with the bleeding. So, and what's the cause of the bleeding? The thrombocytopenia. So it's going to cause thrombocytopenia, and it's going to cause affectation of the endothelial cells in the capillary, which causes extravasation of plasma into the tissues. So it can dilute, it can concentrate the red blood cells, so they can have increased hematocrit. Now there's something we call antibody dependent enhancement of disease. So I'm just going to try to make the explanation very brief. Please, let us try and follow. Now, this antibody dependent enhancement of the disease is the reason why dengue fever can cause dengue hemorrhagic fever. Primary infection doesn't typically cause this dengue hemorrhagic fever. The dengue hemorrhagic fever occurs when you're having second infection with dengue virus of another serotype. Maybe serotype, I think we have about 4 serotypes for dengue. So if somebody has dengue infection for the first time and it's resolved, then secondly is now having infection with another serotype, that one is going to come in very severe and can progress to form the hemorrhagic fever. Why? Because of the antibody dependent enhancement of disease. ADE, antibody dependent enhancement of disease. What does it mean? Do you guys remember the concept of neutralization by antibodies? Anybody? Dr. Babayinde must have said it when we were talking about antibody function. We said antibody can do 3 things when they bind to the organism. What do?
They can destroy the cell.
They can
They
destroy.
can
They can destroy.
cause inflammation.
They can cause.
Or they can
neutralize.
Neutralize.
Thank you, Dr. Sulia. So the neutralization is more like we are preventing it from attaching to the cell that is going to infect. That's the neutralization. Now, what happens is that if you have a primary infection with dengue virus now, you are going to produce antibody against the dengue virus protein, right? Those antibodies are there. Now, if you are now getting infected with another serotype that's having another serotype protein, having another protein on its surface, The antibody that is there might not respond to that one adequately as it's going to respond to the initial one. So the antibody that's already there will bind with little affinity. They will not be able to neutralize it and prevent it from binding to the host cells. Now, what will happen? One thing about antibody-dependent phagocytosis is that for you to have that phagocytosis, you guys need to picture it as that you need to bind that antigen firmly. The antibody-antigen interaction needs to be very firm and avid. It has to be like very, very, what's the word to use now? It has to be very tight. Do you guys get that? It has to be tight. So once it's tight, it can key the antigen down so that the phagocyte can bind to the Fc portion of the antibody and now engulf that virus. Does that make sense to us? You know that when a virus enters, antibody is going to respond to the antigen on it.
Yes.
Yes. Now, when the antibody binds to the antigen on it, the antibody have what we call the Fc portion. Now, that Fc portion is for complement to bind to or for phagocyte to bind to.
Yes.
When phagocytes bind to that Fc portion, what will they do? They will try to now engulf that antigen, so that they can neutralize it, so that they can digest it. Now, for that engulfment and digestion to happen, your antibody must be firmly holding down your antigen, must be firmly holding down the virus, so that the phagocytes can be able to digest it. Now, if the interaction between the antibody and the antigen is weak, your phagocyte can engulf that virus, but it will not be able to digest it. That is very important to understand. So that is the problem in antibody-dependent enhancement of the disease. If somebody has infection with one serotype of dengue virus, the person have antibody against that serotype. When another serotype is now entering, you know that to respond to that serotype, you need to produce its own specific antibody, and that can take time. You guys remember that adaptive immunity takes time to develop. It's not like natural. I hope you guys remember that.
Yeah.
Yes.
It is the initial antibody against this first serotype that will try to respond to it. Of course, they are all dengue viruses. They can share some similarity, although they will have some differences because of the fact that they are different serotypes. They share the same genome, but different serotype. So they will have some little differences between their surface protein. That is exactly what is happening in the antigenic drift. So the antibody that we have that we have initially in circulation, can respond to that antigen, but it will not bind to it firmly because it's not very, very complementary to it. Are you guys following? Me?
Okay.
Yeah.
So it will bind
So
to
called waste time.
Like it's not used to that particular serotype, so it will bind weakly to it.
It will bind. So it's going to bind with it because it's actually coming from the same genome. They are coming from all of them. They are both dengue. It will not bind to it at all if it's like yellow fever, because that is a different genome, a different organism entirely. Does it make sense to you guys? I don't know if you guys get what I'm saying.
Yes, now we get.
Yeah. So now the antibody is going to bind to it, but weakly. And once it binds to it weakly, the phagocyte will come around, they will engulf it, but they cannot digest it. So the virus will now use that phagocyte engulfing to proliferate. They proliferate and they move out and infect the cell. That is the principle of antibody-dependent enhancement of disease. So the viremia with the secondary infection by another serotype is going to be higher than primary infection. The viremia is going, because it has a site to proliferate now. They replicate so quickly within that phagocyte, and they live and they infect the host cells using the antibody as a needles to do that. They just deceive the antibody and they can find their way to the phagocyte and replicate and cause the problem. So that one, because of the high viremia, they cause hemorrhagic fever. And we said how the hemorrhagic fever. So the virus is going to get distribution into the blood, start destroying all the cells, destroy red blood cell, cause hemolysis, destroy the thrombocytes, cause thrombocytopenia that will now lead to bleeding, destroy the endothelial cells that will now lead to establishment of plasma, which will lead to, the hemorrhage. So when the establishment is now too much, it can lead to shock when there's a circulatory collapse. So that's one of those things we are scared of with respect to dengue. How do you want to make diagnosis? You can look for the antibodies by serology, or you can do PCR. You want to look at the genome. That's what you are interested in. But it is reverse transcripted. Why? Because this guy, the RNA, and PCR only sequences like your DNA, replicate your DNA, if you guys remember. So you have to convert that RNA to DNA by using your reverse transcriptase. So once you add reverse transcriptase, convert it to DNA, you sequence that DNA through your PCR. That's why we call it reverse transcriptase PCR. You use it to determine RNA viruses. How do you want to treat chikungunya? It is supportive. There's no vaccine for chikungunya. You can just give steroids and DMAT. So you can give DMAT like methotrexate, like disease-modifying rheumatoid arthritis. So you can give methotrexate, you can give sulfasalazine, you can give hydroxychloroquine. Those guys can work to treat the arthritis, the chronic arthritis. We've mentioned it, that chikungunya have chronic arthritis and they have minimal bleeding. They don't typically bleed. So you can give steroids to minimize the inflammatory arthritis, or you can give DMAT. Don't forget, you minimize mosquito exposure, the Aedes, there's no vaccine available. Now, for dengue, it is also supportive, but because of the bleeding, you must ensure that you are giving fluid or blood to replace the fluid that you are losing, particularly those with the circulatory collapse. There's a vaccine for dengue, but that vaccine is a recombinant vaccine. Which other organism do we know that has recombinant vaccine? Anybody?
That was toxic.
Vaccine.
Which one?
The
It's very
Pneumococcal vaccine.
pneumococcal. No, recombinant, not conjugated. Recombinant.
DPTs. The DPTs.
DPTs. No, I doubt it. The recombinant that is
COVID.
popular. No,
COVID.
Influenza.
COVID is not. COVID is just mRNA. Well, it's a form of recombinant. We can take COVID because you are giving mRNA that will now give protein okay. But the common one is
HBV. Ngo.
HBV.
How does
HBV.
pneumococcal? Okay.
HBV. HBV is a recombinant. That's in fact, is the most common recombinant vaccine. HBV virus, HBV vaccine. You must always remember that. So what they are doing with this recombinant vaccine is that the problem with dengue is that you must be able to develop vaccine against all the serotype, and that has been difficult. That is why since 1920 they could not develop a vaccine against dengue until they were able to find a way to make a vaccine that can take care of all the 4 serotype. Because if you are developing one vaccine now, what about the other serotype? So because of the fact that it has 4 serotypes, it's very difficult to. So they were able to make a vaccine that can take care of all the 4 serotypes. So just imagine you'll be making vaccine against serotype 1, vaccine against serotype 2, and you'll be injecting everybody against dengue. 4 vaccine for dengue. You can even predispose the person to another thing. So they are looking for a single vaccine that can take care of the 4 serotypes. So
But Dr. Babali, is it not better than influenza that has many serotypes?
No, that serotype of influenza 2 is reformed. It's just one single vaccine. It's not as if you are giving vaccine 1 for serotype 1, vaccine 2. No, you are giving a single vaccine that can take care of everything. Do you get it?
Okay.
So it's a reform. It's containing the antigen against all the influenza strain that they think they can cause the next outbreak. That's what they are doing. So for this dengue 2, what they now did was they now try to get yellow fever. So they took yellow fever protein and they removed, the envelope protein for yellow fever. They removed the protein against some portion of the capsid. They now replaced those areas with the complementary portions from dengue. So that's what they did. So I can't remember the exact portion now, but I know that the envelope protein is there and part of the capsid protein too is there. So they now replace that with capsid protein and envelope protein from the 4 serotypes of dengue. They now put it into the backbone of yellow fever virus. They remove that of yellow fever. They now replace it with, that of the dengue. Then, they're able to give people. So they call it dengue.
Is that what makes it? Is that what makes it recombinant?
That's what makes it recombinant. So you are combining with another with another backbone, another virus. And this situation now is yellow fever. That is it.
So with hepatitis B, what is it being combined with?
I don't know the details for hepatitis B. So I
Okay.
just know that hepatitis B is also a recombinant virus. Yeah, a recombinant
Okay.
vaccine rather. So yeah, so that's that about the dengue. So with that recombinant vaccine, you can take care of all the four serotype for dengue. Yeah. So you can see here they even talked about the yellow fever backbone with insertion of gene for the envelope. Oh, it's even here. Envelope and the pre-membrane protein for dengue. That is it. That is it. So it means that this vaccine is not going to confer immunity against yellow fever. Please don't be deceived. It will not provide immunity against yellow fever. It's only because it is only the antigen of dengue that is there. So that is that. So there's no vaccine for chikungunya, but there's a vaccine for dengue, and you need to treat the intravascular volume depletion in dengue. So yellow fever, flavivirus, Aedes, monkey and human reservoir, they are the stores. What did they present with? High fever, black vomitus, jaundice, hemorrhage, and backache. So we've talked about it. We said it already. It affects the liver, so it causes jaundice. It causes coagulopathy, leading to bleeding in the nose, in the GI, in the small intestine, everywhere. And by the time you are vomiting, it's going to contain black vomitus. And one thing about yellow fever is that it typically causes muscle pain. And the muscle pain typically occurs at the back. I don't know why, but it causes typical muscle pain at the back. And what do you see on liver biopsy? Calcium bodies. Don't forget, calcium bodies is peculiar to yellow fever virus. Calcium bodies. Yeah, they're actually eosinophilic apoptotic globules of yellow fever virus. So what they do is that they infect the hepatocyte, they kill off those hepatocytes, they die off by apoptosis. And one thing about apoptosis is that apoptosis forms apoptotic bodies. So those bodies are what you see as the eosinophilic apoptotic, globules. Councilman body, you must always remember that for yellow fever. Councilman body, they are eosinophilic apoptotic bodies due to the cell death from the infection from the yellow fever. You see that on liver biopsy. So you must give the yellow fever vaccine, which is a live attenuated vaccine in people that are traveling to endemic countries. Very, very important. I think they call that yellow card or something, guys. I think yellow card. Yeah. So Zika is the last one. Flavivirus, it's part of the HBWXY. So it's WYZ. Sorry, there's no W. Sorry, Mr. I'm even mixing it up. What's the code again, guys? HBWYZ. Abby? Hello, guys. You guys are not answering me. HBWYZ is not hex. So the HB is the
Yes,
hepatitis
correct.
C.
HD,
HD rather.
HDWYZ. Yeah.
Thank you, Dr. Francois. HDWYZ. So the H is the hepatitis C. The D is the dengue. The W is the Western Nile, which is associated with aseptic meningitis, meningoencephalitis, as well as the flaccid paralysis, just like polio. Once you remember polio, you will not forget it. Asymmetric flaccid paralysis and the meningoencephalitis. Then the YZ, the Y is what? Is the what's the name
Yellow
of it?
fever.
Yellow fever. Then the Z is the Zika. So we've talked about Zika. Three things: the pyrexia, the itchy rash, and the conjunctivitis. So it's one of those things that can cause Guillain-Barré in addition to Campylobacter. I think I've said it before. It can cause Guillain-Barré. So when there's a previous infection with Zika, the person can develop Guillain-Barré. There's no definitive treatment too. It's supportive. So you see the same thing, serology of reverse transmission. They can transmit it sexually and vertically. So we said these two. It's transmitted sexually and vertically. So as well as through the Aedes. So if the Aedes put it into somebody, the person can transmit it to another person sexually, or the mother can transmit it to the child. So what do you see? It can lead to miscarriage, abortion, or congenital Zika syndrome in a woman that is infected. If you do a brain imaging, you are going to see ventriculomegaly as well as subcortical calcification. So calcification of subcortical structures like the internal capsule, the basal ganglia, and all those things, they will calcify, and there will be ventricular enlargement. But don't be deceived that you are still seeing microencephaly. You are seeing microencephaly because this guy causes atrophy of the brain. Like there's failure of neuronal migration. You don't even have proper arrangement of the neurons. There's atrophy of the cortex of the brain. So the brain matter is highly reduced. You see these guys, they will have head that is looking like an encephaly. It's like they don't even have any brain. If you look at the picture online, you guys can check online. Congenital Zika. They don't have, it's like they don't have brain. It's because of the fact that, okay, the ventricles are enlarged, but the brain matter itself is not there, is reduced. So that's the reason why they have microencephaly. And the ocular anomalies they can't see because of the optic atrophy and motor problems like spastic seizures and paralysis. So guys, that is that about that's that about the viruses. So we'll start looking at questions tomorrow. We're almost done. The other ones, they are just recap of what we have done. If you look at all these things, they are just like talking about what we have done again. Look at these things now. We've talked about these things now, right? Guys, look at this. Everything that is here, we know it. Hello?
We just go through it.
So we are not going to waste time. So look at the rubella again here. This is the rubella. This is a blueberry muffin. Look at this. This is likely to be what? Anybody? This one. Anybody? This image B.
Congenital
Adenovirus.
Eh? Hello? We should just say anything.
Is it that
Eh?
October?
Is it what?